All right, today I will be giving a presentation on being crisscrossed by cross-reactivity and just how we can kind of clear up confusion in beta-lactam allergies. I am Connor Dowling. I am one of the PGY-2 ID Pharmacy Residents here at Norton Healthcare. And just before we kind of go further, I did want to go over our learning objectives today, and this is really going to be reviewing our beta-lactam side chains and their role in cross-reactive allergies, as well as applying the updated 2022 allergy practice parameter recommendations and just how we can use those to delabel patients' penicillin allergies. In terms of my financial disclosures, I have none. And really just to kind of break down this presentation, because it is a little bit lengthier, is just kind of an overview of the topics we're going to be touching on today. So we're going to start off going over our key concepts of beta-lactam allergies, followed up by kind of taking that background and looking at how it has been used in this drug allergy 2022 practice parameter update, see the recommendations that were made in that, some of the guidance that this gives us, and how we can apply that practically in terms of our beta-lactam management in patient care. And so without further ado, we will just go ahead and jump straight into some of our key concepts of beta-lactam allergies. Specifically, we're going to be looking at our incidence, impact, and the role of these side chains, and just some of the background information that can kind of help us get to where we will be able to understand and apply that practice parameter updates. So I just wanted to start off this presentation kind of talking very briefly about hypersensitivity reactions. As you can see here, there are several different types, and actually this is just one type of the ways that we can classify hypersensitivity reactions. This is the Coombs classification. There are other ways, but throughout this presentation, if you hear me talk about type 1, type 2, type 3, or type 4, this is what I'm referring to. And more specifically with this presentation, we're going to be focusing in on our type 1 IgE-mediated reactions. These are going to be reactions that are characterized by anaphylaxis, urticaria, or hives, so urticaria being hives, or angioedema. As you can see, this is an immediate type reaction, whereas type 2, 3, and 4 are all delayed reactions. Some of the other differences between these reactions is the way that they are mediated. As you can see here, type 1 is mediated by IgE, whereas type 2, type 3, and type 4 are either mediated by IgG, IgM, or they could even be T cell mediated. Some of the differences between these two that we really want to focus on besides our type 1 is these type 4 reactions, as these can also present as a kind of cutaneous reaction, similarly to our urticaria and hives, but these are going to be classified more so as a severe cutaneous adverse reaction. So when we're thinking of our severe cutaneous reactions, this is going to be our Stevens-Johnson syndrome or SJS. This is going to be our toxic epidermal necrolysis or TEN, and then drug reaction with eosinophilia and systemic symptoms. So this is something that we're going to want to characterize that difference because we cannot treat a type 4 reaction as we would a type 1, as we'll get into a little bit more detail later in this presentation. But to just kind of kick us off with like what we would even expect to see in terms of these different reaction types, these hypersensitivity reactions in the EHR, I think this is best exemplified by just what we would commonly see when we see our allergies listed in EPIC in the EHR. So, for example, this patient has a history of penicillin allergy. They don't specify the severity, but they do mention that this is hive, so urticaria. This is that type 1 kind of look. They don't really give us any sort of comment into it, but that's kind of what we're thinking here. Similarly, this is another penicillin allergy, this time rated as a highly severe reaction. And they kind of mentioned that shortness of breath and swelling from around 11 years ago. And both of these are, as I mentioned with the first one, these both classify as a type 1 immediate reaction. So this is what we're thinking of more of a true allergic and anaphylactic reaction, specifically when it comes to that shortness of breath and swelling. In terms of another example here, so with this patient with another penicillin allergy, a high severity, we do note though here in this comment that while they do tolerate some cephalosporins, it actually stated that the patient's skin sloughed off after they took penicillin. So this is a bit more concerning for one of those severe cutaneous adverse reactions, and we would be leaning more towards identifying this as a type 4 reaction rather than that type 1 allergic anaphylactic response. In terms of this last one, this is an example that I'm sure we've all been very familiar with. Another penicillin allergy, except here the patient just denies that they even have an allergy. He just reports that he developed an immunity against the antibiotic because he received it a lot as a kid. And this is one of those that is kind of a great example of a non-allergy or intolerance. So this could be also seen where, this could be someone reporting a side effect of the antibiotic, such as diarrhea, vomiting, nausea, just a preference. They don't want to take penicillin, so they kind of put it in the chart. But these are kind of where we might see some of our intolerances or non-allergies. And you might be wondering, well, why does it matter? We can kind of piece through that and see that these don't look like a true allergy. But there is actually some impact when we think about this. So with our incidence of penicillin allergies, true penicillin allergies are actually rare. So thinking of those type 1 mediated reactions, this is going to be a rare instance. Intolerances and non-allergies actually account for around 90% of our labeled allergies that we have for our patients. So when we look at the true incidence of allergies, about 10% of our population in the US has a documented penicillin allergy history, but 90% of that 10%, so actually around 1% of our true population has a real penicillin allergy. So we actually have a lot of these intolerances or false allergies that kind of confuse and really get labeled inappropriately in our chart. And this really does, like I mentioned, have an impact on our patients and our patients' outcomes. Just using or having this labeled allergy in the HR is going to frequently lead providers to selecting second-line agents such as fluoroquinolones, trimsulfa, etc. And these can have a bunch of different side effects, a bunch of different consequences that we might not see from our first-line beta-lactam therapy. And some of these include increased antimicrobial resistance, an increased risk of patient mortality, increased healthcare utilization for our patients, increased risk of surgical site infections, and even increased time to the first dose. So while we might think that some of these labeled allergies are innocuous, there are some consequences that we really need to consider when we're reviewing our patient chart and kind of considering how their allergy might come into play when we select our antimicrobial therapy, specifically for beta-lactams. And really, when it comes to how we differentiate our allergies between different beta-lactam classes, so beyond just the penicillins, we really can look at the structure of a beta-lactam and their side chains. So as you can see here, all of our beta-lactams, whether it's a penicillin, a cephalosporin, a monobactam like aztreonam, or a carbapenem, they all share this beta-lactam ring. The one difference, though, that we see between each of our different drug compounds is going to be where we have our different R group side chains. And these R group side chains are what are thought to be our primary source of mediating allergy and cross-reactivity. So when we think of having beta-lactams that have similar side chains, we might think that cross-reactivity risk increases. Similarly, if someone has a dissimilar side chain antibiotic being administered when they have that history of a penicillin allergy, for example, then we can kind of go forward with that and not be as worried when it comes to our cross-reactivity risk. But just to kind of characterize the differences when we're thinking about our risk of cross-reactivity with penicillin allergies, really between different groups, our cross-reactivity is much lower than what was previously thought. So previously, we thought there was about 10% risk of cross-reactivity between penicillins, cephalosporins, but that was really based on old data and actually how these drugs used to be manufactured. Up until the early 80s, a lot of our early generation cephalosporins were contaminated with penicillin. And we also had reports back from the 80s and the 90s that were reporting adverse effects as potential cross-reactive allergic reactions as well. So we were seeing kind of this contamination effect as well as potential side effects being reported as allergic reactions, where we were thinking in the past we had this higher rate of cross-reactivity. But now kind of looking at what we've seen in more recent literature, cephalosporins with dissimilar side chains from penicillin actually only have around a 2% chance of cross-reactivity with that penicillin allergy. Cephalosporins that do kind of share those similar side chains with penicillin, which we will touch on here in a moment, this risk is going to be higher. So when we do have that similar side chain, we have that increased risk of cross-reactivity. And this has really been found to be anywhere from around 30 to 40% for our risk of cross-reactivity with those similar side chains in our cephalosporins and a penicillin. Now, when we look at carbapenems and monobactam, this risk is much smaller than what we'd see with our cephalosporins, whether that is similar or dissimilar side chains. Specifically for carbapenems, our risk is less than 1% cross-reactivity with a penicillin allergy. And aztreonam, the monobactam, is even smaller than that with almost a less than 0.01% chance. And when we get to these percentages where the chance is so low that we have cross-reactivity, we might actually need to start considering that a patient actually has a unique and separate allergy to the monobactam aztreonam, rather than a cross-reactivity with aztreonam and someone's amoxicillin allergy, for example. But kind of coming back to our structurally R group or our structurally similar R side chains, as I mentioned, there are different antibiotics, specifically beta-lactam antibiotics, that do share these similar side chains with one another. And as I've mentioned, these are where we'll have that increased risk. So for example, when it comes to penicillin G, structurally similar R side chain is seen in cefoxitin. Whereas with ampicillin and amoxicillin, we see that structurally similar R side chain in cefaclor, cefadroxil, cefprozil, and cephalexin. However, on the other hand, ceftriaxone, that third generation cephalosporin, has a similar structural side chain to cefotaxime, cefpodoxime, and cefepime. Aztreonam, as I mentioned, has that very low risk of cross-reactivity between it and a penicillin allergy, but it does actually share a structurally similar R side chain with ceftazidime. So this is one of those situations where if you're using aztreonam to potentially get around a cephalosporin or a penicillin allergy, if they had a true allergic reaction to ceftazidime, we would actually probably want to consider something beyond or besides aztreonam in this instance, because they do share that structurally similar R side chains. And one thing that's also kind of been in the mix when we think about our structural similarities, our R side chains, our chance of cross-reactivity, is that we can determine our structural similarity just by cephalosporin generation. But this is actually not a reliable predictor for cross-reactivity when we start looking at some of the differences between our side chains and just our beta-lactam antibiotics. For example, a great example of this is actually with cefazolin, which has a very unique side chain that is dissimilar from all penicillins and all beta-lactams. So as we'll see and kind of talk about a little bit more later on in this presentation, cefazolin can be a great option when we need to use a beta-lactam, specifically for surgical site prophylaxis, even if we do or do not know we have a penicillin allergy. And just as kind of a way to contextualize some of this, I did want to go through an example cross-reactivity chart to just kind of let you guys be able to see how we can look between generations and if this is always a reliable way to predict whether or not we're going to have that similar structure when it comes to our R side chains. So as you can see here with this graph, we have a nice array of our penicillin antibiotics followed by our cephalosporins and both the Y and X axes. And really what we're looking at here is when we have our antibiotic over here, our penicillin and let's say amoxicillin, this space indicates where they would interact. So if you do not see an X here as you see in this space, there is no structurally similar R side chain. However, with ampicillin and amoxicillin, they share that structurally similar side chain. And then similarly with amoxicillin, we're just going to have that grayed out, blacked out here to kind of denote that this is the same antibiotic. But in terms of what we would see between different beta-lactams and kind of where they might cross-react, we'll go ahead and start with cephalexin. So as you can see here, cephalexin, as I mentioned, shares that similar R side chain with amoxicillin, ampicillin, and cefaclor. So these are going to be situations where if we were administering cephalexin for a patient that had a history of an allergy to any one of those three agents, we would really be concerned for that risk of cross-reactivity. Cefoxitin, on the other hand, does only share that similar side chain with penicillin, but does not actually with ampicillin or amoxicillin or cefaclor. So this kind of starts to where we can see that debunking of our generations being able to determine our cross-reactivity by themselves. And then ceftriaxone, a third generation cephalosporin here. So we're not going to see that similar cross-reactivity between penicillins or any of our earlier generation cephalosporins, but we do see that similar side chain when we look at cefepime, cefpodoxime, or cefotaxime. Cefazolin, as I mentioned, this has that very unique, the special side chain. You'll hear me talk about it a few more times during this presentation, where it does not have that similar side chain with any other beta-lactam antibiotic. So this is really our unique scenario here, and a great example of why we can't always just rely on a generation to determine whether or not our side chains are similar. And it's just a quick knowledge check for everybody. Just wanted to go through this one with you guys, just kind of walk through how we might assess whether or not we have a similar side chain here. So this question, which beta-lactam shares the side chain similar to amoxicillin? Is it A, cefazolin? Is it B, cefoxitin, C, cephalexin, or D, ceftriaxone? And as we see here, we have our amoxicillin highlighted in green, and we're just going to go through each one and then just see our risk of cross-reactivity, or if it cross-reacts, has that similar side chain at all. So when we look at cefazolin, it has that unique side chain. There is no similar side chain with amoxicillin or any other beta-lactam, so we would have a low risk of cross-reactivity here. Cefoxitin, on the other hand, is also going to have a low risk, but this is going to have that similar side chain to penicillin G, but not to amoxicillin. So we wouldn't have that heightened risk of cross-reactivity if we were giving cefoxitin in an amoxicillin allergic patient. Cephalexin, on the other hand, does share a similar side chain with amoxicillin, so we would be worried about that increased risk of cross-reactivity. And finally, ceftriaxone does not share that similar side chain with penicillins or any of the similar cephalosporins, and we'll kind of touch on this a little later, but we're really concerned with our risk of cross-reactivity when we're thinking of something like cefepime or cefotaxime or cefpodoxime. And really, this is a great time for us to just kind of feel like, well, now that we know some of the background on why we're concerned about different cross-reactivities with certain beta-lactams, but not others, to just go ahead and go straight into our 2022 practice parameter update on drug allergies and really look at our evidence-based guideline recommendations. And so for this, there are a ton of recommendations that they make in this guidance document. They go through, and it's not just on beta-lactam antibiotics. This is on a wide variety of different medications, but today we'll be focused specifically on their recommendations for beta-lactam allergies. And some of these recommendations that I just wanted to highlight for you all, we're going to start off by talking about our proactive allergy delabeling and just kind of how we go about that when we're thinking about our patients that have these labeled beta-lactam allergies. And this is really going to kind of focus back onto what we talked about earlier with our incidence of true beta-lactam allergies, which is actually very low. So like less than 1% of our actual population having that true beta-lactam allergy. So we really want to think about being able to proactively delabel our allergies to help out patients and improve their outcomes. Likewise, this recommendation for penicillin skin testing is mentioned throughout this document, and we will touch on this a little bit when we get to that section. And then finally, we'll also begin to talk about drug challenges and ways that we can kind of determine whether or not a patient is a suitable candidate and possibly use this as a way that we can help delabel our patients with a labeled beta-lactam or specifically penicillin allergy. But to just kind of start off with our proactive allergy delabeling and kind of how we go about this and what the guidelines kind of recommend when we think about how we should look to delabel our patients, this is something that is going to require a lot of multidisciplinary support and education. So delabeling our patients should not be something that is done in isolation. This is something that requires education for not only the patient, but also the providing team. And this is something that when we talk about our own protocols here, we'll look into a little bit more on like what we would do in terms of practice here. But specifically in general, this is something that requires a multidisciplinary discussion and just having that open education, explaining the benefits of why we want to delabel, improving the patient outcomes by using our first line recommended treatment, and hopefully getting them out of the hospital sooner. So another big key factor here is that we really want to prioritize the right patient when it comes to these patients that we might be able to delabel. So this is someone that can likely tolerate the beta-lactam in general. So we want to make sure this is an allergic reaction, but not an anaphylactic reaction. Likewise, we want to make sure that patients haven't had any of those other types of hypersensitivity reactions. So would really want to avoid it if we had the history of a type 4 mediated reaction like Stevens-Johnson syndrome. So we'll talk about some of the inclusion-exclusion criteria for patients that meet our delabeling criteria here, but in general, prioritizing that right patient to do this is really important. And remembering that we can do this for people that are here for non-infectious causes. So that can oftentimes be one of our best areas of opportunity when it comes to proactively delabeling our patients. And then finally, one of the biggest key points here is to remove the allergy from the EHR when we are done with our proactive allergy delabeling. So this is one of those things that's really important to emphasize, not only to the patient, but to the providing team, that once they have their allergy removed or potentially have tolerated their drug challenge, kind of clearing them that they are able to remove that allergy from the EHR, patients should be educated that once they have left the hospital, they really should go to their primary care provider, let their providers know that, hey, I tolerated this beta-lactam, or hey, I had a discussion while at the hospital and I found out I'm actually not allergic to penicillin. And if you please don't mind removing this from my EHR profile, that'd be fantastic. And just having that conversation with our patients to make sure that this doesn't just make an intervention now, but for future admissions or just outpatient care as well. In terms of some of our other recommendations, looking at our penicillin skin testing, this is something that is routinely recommended in the 2022 practice parameter guidance, but it is really reserved for a history of patients with an anaphylactic reaction to a beta-lactam or penicillin antibiotic. So this is something that's not going to necessarily involve as much of a group discussion. This is something that's going to generally require technical skill to be able to pull off. This is going to need someone that is adept in being able to perform our penicillin skin test, as well as being able to read it appropriately to give us a good idea of whether or not this skin test is positive or not. So because of this, this is not really a routine practice for inpatient adults here at Norton Healthcare, but because we don't really prioritize this as much, just because of some of the logistics of being able to perform this while inpatient, we do utilize the other recommendation when it comes to delabeling our patients, and this is through direct drug challenges. So you might be wondering, what's the difference between a drug challenge and normal administration? And really, the difference is that a direct challenge is an administration with observation, whereas our normal administration is going to have that administration without any need for observation. And while with observation might sound pretty serious, almost scary even, this is going to be a situation where, we still give it, we educate the patients what to expect if they have any sort of reaction, and just kind of can prompt the nurse to come in and check a few times over the course of an hour. But nothing where they're being sat and handheld one-to-one supervision while we're doing our direct challenges. But this should be also mentioned that our direct challenges are not without contraindication. And some of the contraindications that we mentioned here are going to be related to some of those non-type 1 mediated hypersensitivity reactions. So the SCAR, or severe cutaneous adverse drug reaction, so our Stevens-Johnson syndrome, our toxic epidermal necrolysis, these are going to be a complete contraindication to doing our drug challenges, as we're not going to be going around an allergic reaction. This is more of that T-cell mediated reaction. Likewise, we're going to want to avoid patients that have a history of a drug-induced autoimmune disease. So something that could be like a drug-induced lupus, for example. Organ-specific drug reactions are also going to be a complication that we would have a strict contraindication to when performing our drug challenges. So this could be if someone had a history of drug-induced liver injury from penicillin, or drug-induced nephritis, meningitis, pancreatitis, etc. These are going to be contraindications to our drug challenges. Likewise, a history of anaphylaxis, so a patient that's going to have some of our allergic symptoms like our hives, the urticaria, with shortness of breath, with angioedema, or just shortness of breath and angioedema by themselves, where we're going to want to have a real close look to make sure that this is anaphylaxis. If it is, contraindication to our drug challenges. And we'll kind of talk a little bit more about what we should expect to see with that when we go through some of our step-by-step recommendations from this 2022 allergy update. But in general, drug challenges are going to be done as a 1 or 2 step challenge, which we'll talk about a little bit here in a second. And we're going to want to focus in on adults that have a distant, so at least 5 years, or benign cutaneous reactions when we're thinking about our patients that we can do our drug reactions in. So this is when we're talking our benign cutaneous reactions, this is going to be a rash, our hives, without any sort of organ involvement, so no nausea and vomiting associated with the hives or rash, or just none of the swelling, none of the angioedema, none of the hypotension. These are going to be our benign cutaneous reactions and limited to that. So you might be wondering, well, what do I do for a 1 or 2 step challenge? Is there a difference? Do I need to worry about a difference here? Should patients be receiving one or the other? And as you can kind of see in the guidelines that do touch on two-step reaction or two-step challenges pretty frequently, but there is actually no real difference beyond how we administer the two. So our one-step reactions is going to be a full dose administered once, whereas our two-step challenge can be seen as a graded dose challenge. This is where we're going to give a small fraction of the dose, then finish the full therapeutic dose around 30 to 60 minutes later in a two-step challenge. So as just an example of that, if we did a two-step challenge for amoxicillin, we could give 10 milligrams of amoxicillin as the initial step, and then finish with 490 milligrams 30 to 60 minutes later to complete that two-step challenge. Whereas our one-step challenge could be giving amoxicillin 500 milligrams once just to challenge that history of allergy. Likewise, these challenges do not need to be limited to oral challenges. We can also challenge with IV antibiotics, which we'll see a lot of times with our IV cephalosporins. So if we're challenging with ceftriaxone, this can be done as a one-step IV administration of ceftriaxone. But here at Norton Healthcare, for our inpatient adults, we do primarily utilize our one-step challenge. And this is really just to kind of streamline the process, make it easier for the patient, for the nurse, and for pharmacy alike, just to get it to where we can just administer once, observe, and avoid having to go back and re-administer and split doses as well. But in terms of another kind of delineation, because there are a lot of different terms when we think about our allergies, I'm sure you all have heard about challenges versus desensitizations. So I just did want to provide a little clarity between the two. In general, they are not the same reaction. So a drug challenge is used for a drug challenge and desensitization are not the same process. In general, drug challenges are going to be utilized for our lower risk reactions, whereas desensitization is really going to be a tool for using a specific antibiotic that has that anaphylactic history to it, but is needed clinically for a certain scenario. So this might be a situation where a patient with an anaphylactic history of penicillin, it needs IV penicillin to treat their neurosyphilis. We would actually go through the desensitization process and provide that temporary induction of drug tolerance as they clinically require that IV penicillin to treat their neurosyphilis. And this is something that's really important too when we think about our drug challenges versus desensitization, that desensitization is only a temporary induction of tolerance. So when we desensitize someone, they're only going to be tolerant of the drug as we give tiny little incremental increases in the drug to be able to let them tolerate the full therapeutic dose for the course of therapy. Whereas a drug challenge is we're just trying to assess whether or not there is a true allergic reaction when a patient receives this dose of antibiotic. But without further ado, I would like to take us on into one of the real meat and potatoes of our 2022 drug allergy update, and this is their allergy assessment pathways. So our allergy assessment pathways are really where we can kind of see how we can take our risk of cross-reactivity, our different beta-lactams, and what do we do with this information when a patient has a history of an anaphylactic or non-anaphylactic reaction? Can we administer something or should we avoid it? And so we're just going to start off here with our cephalosporin administration to patients with a penicillin hypersensitivity. So when we look at this here, we can see that there are two distinct ways that we can start this pathway. First of all, we can start with our structurally similar cephalosporin being given. So this could be a situation where cephalexin is being given in the patient with a history of an amoxicillin allergy, whereas on the other side, we have our structurally dissimilar cephalosporin being given. And to kind of continue with that same analogy, a patient being administered with ceftriaxone, but they have a history of amoxicillin allergy. So we'll just go ahead and start with our structurally similar cephalosporin being given. So this patient potentially has a history of an anaphylactic reaction to amoxicillin. They had some shortness of breath, they had angioedema, they had hives, they could have hypotension, or they could even have, the hives with any sort of organ involvement. So this could be hives with nausea, hives with vomiting. This is kind of looking towards that anaphylactic history. If a patient is being given that structurally similar cephalosporin, we would generally want to recommend a penicillin skin tested guiding treatment. But as I mentioned here at Norton Healthcare for our inpatient adults, we would actually not be performing that skin test and we would just avoid using our structurally similar cephalosporin because of that. However, if a patient had a non-anaphylactic history, so just a rash after receiving a dose of amoxicillin 20 years ago or something like that, we could go ahead and give that cephalosporin normally. We would be able to give that cephalexin normally. However, if we have a structurally dissimilar cephalosporin being given in our history of amoxicillin allergy, so our ceftriaxone being given here, we can go ahead and administer that cephalosporin normally, regardless if there is a anaphylactic or non-anaphylactic allergy history. Now, with the caveat there being if they had any of the type 2, type 3, or type 4 reactions, we would not want to administer that cephalosporin normally. And just as a way to kind of contextualize that, because that is a lot of information to walk through pretty quickly, I did want to go through this example case and just show you how we can apply this to different antibiotics when we're thinking about patients that have these history of allergies. So just to start off, this 48-year-old male has a history of hives and shortness of breath after receiving amoxicillin 9 years ago. Which antibiotics are safe to administer normally for our patient? Is it A, cefepime, B, cefazolin, C, cephalexin, or D, ceftriaxone? And just as we go through this, we're going to go through it in a stepwise fashion and just really try to utilize that algorithm to be able to go through and discern whether or not our antibiotic selection is going to be safe and appropriate for our patients. So step one, we're going to look to see if there's even a penicillin allergy documented for our patient, which we do. We have that penicillin allergy history documented. We see that shortness of breath and hives. So this is going to kind of clue us into more of an anaphylactic history, where we're going to see that shortness of breath really highlighting our concern for anaphylaxis and going to put us in that category. So we're now going to be starting with that when we're thinking about our antibiotic selection. So our third step, which leads us into assessing the side chains themselves. So when we assess our side chains, this is where we're going to look to see whether or not our patients have a similar side chain with cefepime and amoxicillin, cefazolin and amoxicillin, cephalexin and amoxicillin, and ceftriaxone and amoxicillin. Our fourth step will actually be to apply our allergy assessment pathway and utilize that pathway along with our side chains, our history of allergy to make a good clinical and safe clinical decision with regards to which antibiotics are appropriate for this patient. So just coming back to our wonderful side chain chart and just kind of highlighting our amoxicillin once again, we'll just go through each of these and kind of remind ourselves which of these have that risk of or heightened risk of cross-reactivity. So cefepime, we're in the clear here. There is no heightened risk of cross-reactivity as it does not share similar side chains with amoxicillin. Similarly, cefazolin, although it is an early generation cephalosporin, has a unique side chain dissimilar from all other beta-lactams, and it would be safe to give in this situation. Ceftriaxone, a third generation cephalosporin over here, like cefepime, we wouldn't be concerned with that similar cross-reactivity risk since we have dissimilar side chains with amoxicillin. But cephalexin actually does share that similar side chain with amoxicillin, so we would have the heightened risk of cross-reactivity when thinking about cephalexin and amoxicillin allergy. So now just kind of looking to apply all of this together, we have our history of our anaphylactic allergy thanks to our shortness of breath and hives. Um, we'll just use this allergy assessment pathway to go through each antibiotic, thinking of our side chains, thinking of our allergy, and how we can go about implementing and administering our antibiotics, or whether or not we should administer our antibiotics. So cefepime, it does have that dissimilar side chain with amoxicillin. We could go ahead and give that normally. Cefazolin, it has its unique side chain. It is dissimilar from amoxicillin. It can also be administered normally. Cephalexin, on the other hand, we really would want to avoid administration, as this is going to be our anaphylactic history, a structurally similar cephalosporin being given. This is where we're going to recommend giving that penicillin skin testing guided treatment, but here we're just going to avoid our administration completely, as that's not routine practice for our inpatient adults at Thorne Healthcare. Finally, ceftriaxone, like cefepime and cefazolin, has a dissimilar side chain from amoxicillin. We can go ahead and administer that normally. And so this is a lot of information. If there is one thing to really take home from our cephalosporins and penicillin allergy histories, structurally dissimilar cephalosporins are safe to administer normally in patients with a history of type 1 reactions to penicillin antibiotics. So thinking about our ceftriaxones, our cefazolins, our cefapimes of the world, when we see those amoxicillin, the penicillin allergies, if they have a anaphylactic or non-anaphylactic reaction, we can go ahead and safely give those structurally dissimilar cephalosporins. And this is really well exemplified by our cross-reactivity with cefazolin, as I kind of touched on numerous times at this point. We have that low cross-reaction rate in unconfirmed or confirmed penicillin allergy. And this is really one of those things where we see a very low either way. So unverified reaction rate, an unverified penicillin allergy has a cross-reactivity rate of only 0.7%, whereas our confirmed allergy is around 3%. So this is also kind of coming back to touch back onto something that I mentioned with aztreonam and monobactams in general, the only monobactam, where we might even see the cefazolin allergy as a unique allergy rather than a cross-reactive allergy with cefazolin and penicillin. But this really makes it ideal for surgical prophylaxis, especially patients that might be emergently admitted for surgery and we don't have the ability to verify their penicillin allergy. We can very comfortably give cefazolin in these patients, even if we don't know their penicillin allergy history. And then just to kind of go through a second allergy assessment pathway, this time we're going to be focusing in on our cephalosporin administration to patients with another cephalosporin hypersensitivity. So kind of thinking of giving a ceftriaxone in someone that has a cephalexin allergy or a ceftonir allergy. This is kind of what we're looking at here now. So going back to our anaphylactic history here, thinking of patients that are going to have a history of dyspnea, the shortness of breath, or dyspnea, the shortness of breath, angioedema, or hypotension, or even hives with the associated nausea, vomiting. These can kind of be what we'd see with our anaphylactic history versus our non-anaphylactic pathway. So just to start off going down our anaphylactic history, we're kind of, regardless of whether or not this is a structurally similar or dissimilar cephalosporin being given, we're really going to want to give a cephalosporin skin test to guide our treatment if there's that history of anaphylaxis. So in these situations, we would just try to avoid other cephalosporins and look to see if maybe someone has tolerated cephalosporins in a different side chain previously before we would consider giving a cephalosporin. As in terms of our non-anaphylactic history, if the structurally similar cephalosporin is being given, this is also going to be an indication where we should probably look to use a skin test guided treatment per our 2022 practice parameter update. Something that we're not necessarily going to do here at Norton Healthcare for our inpatient adults. So really just going to avoid our treatment generally. And in terms of those that are structurally dissimilar cephalosporins, so for instance, a ceftriaxone and the cephalexin, this is where we can actually give that drug challenge to kind of determine whether or not we actually will have that cross-reactivity, that chance of hypersensitivity with our dissimilar side chain cephalosporin. And as just a way to kind of contextualize this similar to our penicillin allergy history patient, I did want to go through this case really quickly with you all and just kind of walk through it to kind of have a better understanding of what we might do when we see our history of beta-lactam allergies. So this 54-year-old patient has a history of hives after a single dose of cefaclor. How should each antibiotic be administered? And the antibiotics are going to be similar to the last one. We're going to look at cefepime, cefazolin, cephalexin, and ceftriaxone. Our first step, once again, do we even have that cephalosporin allergy documented? We do. It is a history of hives, which leads us to our second step, which is kind of assessing, is this anaphylaxis or non-anaphylaxis? For this patient, it is going to be a non-anaphylactic history. It's just hives. We don't see any of that organ involvement with it, so it's not hives with hypotension. It's not hives with nausea. It's not hives with vomiting. It's just hives. So we're thinking of this more as a non-anaphylactic history. And then our third step here is going to be assessing our side chains. So looking at our beta-lactam cross-reactivity charts to see if we have that heightened risk of cross-reactivity by having similar side chains. We'll look at that. And then step 4, just really applying that flow chart from the algorithm that is offered up by the 2022 practice parameter guideline. So without further ado, we'll just kind of go in and assess the side chains. And just for the sake of time here, I will just kind of go through each of these and tell you whether or not it's structurally similar or dissimilar to kind of spare you all from looking at the chart too many times in a row. So for cefepime, this is going to be a structurally dissimilar cephalosporin from cefaclor. Cefazolin is also going to be a structurally dissimilar cephalosporin from cephalospor. They don't share that similar side chain. Cephalexin, on the other hand, is going to be a structurally similar cephalosporin as they do share similar R group side chains. Ceftriaxone, like cefepime, like cefazolin, does not share similar side chains with cefaclor and is a structurally dissimilar cephalosporin. So how do we apply this to our allergy assessment pathway? Well, we have our allergy history of hives, cefepime. It is a dissimilar side chain from cefaclor. We can administer it as a drug challenge. Cefazolin, similarly, we have that non-anaphylactic history. It's a structurally dissimilar cephalosporin being given. We can administer cefazolin as a drug challenge in this patient with their history of a cefaclor hives allergy. Cephalexin, on the other hand, this is a non-anaphylactic history, is a structurally similar cephalosporin being given. This would generally prompt a skin test guided treatment. We're not going to do that routinely here for inpatient adults at Norton Healthcare, so we would avoid administration. Ceftriaxone, on the other hand, can be administered as a drug challenge. It's that non-anaphylactic history, a structurally dissimilar cephalosporin being given, and we can do our drug challenge. So in terms of kind of what do we take away from our cephalosporin administration and our cephalosporin hypersensitivity reactions? Structurally dissimilar cephalosporins may be given as a drug challenge in patients with a non-anaphylactic allergy to other cephalosporins. And then finally, this other allergy assessment pathway is really for administering our penicillins to patients that have the cephalosporin hypersensitivity reaction. So this is going to be a situation where we're thinking of administering amoxicillin when we have a history of a ceftonir allergy, for example. So when it comes to a patient that has an anaphylactic history of a cephalosporin allergy, so thinking of that shortness of breath, the angioedema, hypotension, hives with associated organ involvement, such as nausea, vomiting, or hypotension, we would want to go down that skin-tested guided treatment pathway and really, in our situation, would avoid administration. However, if it's a non-anaphylactic history, we have a history of ceftriaxone rash after administration, we could actually go ahead and give our penicillin normally, or as a drug challenge if someone wanted to do it that way too. But to kind of round out what these practice parameter updates mention in terms of our other beta-lactam antibiotics, carbapenems and aztreonam specifically, we can go ahead and give both of these normally without additional precautions, except whereas aztreonam, we do have that caveat of unless the patient has a history of a ceftazidime allergy. And this is just due to the extremely low incidence of cross-reactivity between carbapenems, between monobactams, and other cephalosporins and penicillin beta-lactams. And so without further ado, now that we've kind of gone through what the 2022 practice parameter update provides us, I just wanted to touch on our practical applications of beta-lactam allergy management, how we can utilize what we just learned, what we've talked about, what the guidance document tells us, and how we can take that to make protocols, improve our patient outcomes, and start policies that can help us really delabel our patients proactively, and help just get them on the right antibiotics whenever we can. So in terms of just our general application to practice, we can look to implement side chain based cross-reactivity protocols and really leveraging beta-lactam cross-reactivity rates to help with stewardship. We can also look to proactively delabel our penicillin allergies by implementing different protocols and processes that can be utilized to help identify patients that are appropriate candidates for challenges, for delabeling, etc. And we'll kind of talk about what's done elsewhere and what we use here at Norton Healthcare for our inpatient adults. So in terms of looking to implement sidechain based cross-reactivity protocols, which I know is a mouthful, but really trying to leverage our knowledge of sidechain and cross-reactivity into implementing protocols, there are a lot of different ways that places have done this to really help reduce second-line antibiotic choices for patients with these labeled penicillin allergies. So this can be done to help with guidance for perioperative antibiotics and a history of penicillin allergy. For example, being able to use one of those cefazolins for patients that do or do not have a verified penicillin allergy history, as well as being able to know that we can use cefazolin comfortably in a patient that even has that history of penicillin anaphylaxis or amoxicillin or anaphylaxis. And really just looking to use that cefazolin and its unique side chain is a great way to have prophylactic antibiotics for surgeries. We can also look to use our knowledge of cross-reactivity to adjust allergy BPAs or best practice alerts when ordering and verifying beta-lactams. So this could be something that that has been done and studied that shows that when we use or when we alter our BPAs to maybe not show a penicillin allergy history of nausea, of vomiting, that flags for a cross-reactivity with ceftriaxone, for example, to take these away, we've found that there is actually not this heightened incidence of cross-reactivity. We don't see extra allergic reactions. We don't see extra anaphylaxis. And it's associated with more frequent utilization of ceftriaxone when we might have stepped away from it previously. But in terms of kind of beyond what we can do protocol-wise, we can also look to have different ways to delabel our penicillin allergies. So this can be done through a few different tools. Our first tool being with different order sets. So this can be a ready-to-use order set for oral beta-lactam challenges that provides really kind of instructions for nurses, education points for the nurses to give to patients, as well as any sort of allergic reaction medication management that might be necessary. So like what we would try to give an allergic reaction response, whether that's like an epinephrine, diphenhydramine, etc. This is something that can kind of make this an easier process for providers to be able to implement their delabeling processes and really look to be able to challenge patients comfortably and effectively. Likewise, we can use delabeling tools such as PinFast, which is used outside of Norton Healthcare, and as well as our own internal ClearPin protocol, which we can use to help identify and delabel our patients with a patient history of penicillin allergies. Likewise, we can empower all pharmacy staff to have this kind of education or understanding of our cross-reactivity with beta-lactams and their side chains, and how the similar and dissimilar side chains can kind of increase or decrease our risk of cross-reactivity. So this really can help us identify low-risk patients, support stewardship efforts, make recommendations on the front line when we get our orders in, and be able to help potentially provide providers with easy support and options for choosing the appropriate beta-lactam, depending on the allergy history. And really, I mean, kind of going from this, I did want to focus in on some of our delabeling tools that are used outside of Norton Healthcare, as well as the ones we use here. And so I did want to touch on that PinFast tool before we kind of talk about what we do here. So the PinFast tool is actually a tool that looks to kind of assess our risk of penicillin allergy. And it uses this kind of stepwise approach to get our different scores to kind of assess where we have this height or low risk of penicillin allergy. So if a patient has their reported allergy history, we can go ahead and proceed this. If it's been within the last 5 years, they get 2 points. If it's been beyond 5 years, it's no points. And then kind of going down below this as well. So if we had an anaphylactic reaction, that's 2 points. If there was a severe cutaneous adverse reaction, so one of those type 4 mediated reactions like Stevens-Johnson syndrome, this is going to be 2 points. And this is just, you're going to give 2 for either one of these. And then treatment required for the reaction. So if someone received diphenhydramine to help treat their rash, they would get another point here. And we take our total points and can kind of use that to identify our risk of penicillin allergy. And this is not going to be a one-to-one, like we have a high risk. It's going to be a for sure penicillin allergy, a for sure risk of cross-reactivity. This is actually going to be our risk of specifically for the probability of having a positive penicillin skin test, not necessarily a true penicillin allergy. So when we think about our high risk here that they mentioned, this is actually going to be about a 50% chance of a positive penicillin skin test, whereas our low risk is going to be more of a 5% chance of a positive penicillin skin test. When we think about our scoring system for the PinFast protocols. But just as a way to quickly kind of give an example on how this is done in practice. So this 78-year-old male has a labeled penicillin allergy from his childhood. He states he had pain at the site where they gave him a penicillin shot when he had it, and he remembers taking diphenhydramine to alleviate the rash. He has tolerated cephalexin in the last 8 years, however. How would PinFast stratify his risk of penicillin allergy? And really, we would just take what we see from our patient history and apply it to our PinFast checklist. So we do see that the patient has a reported penicillin allergy history. So we would go ahead and proceed with our stepwise approach. It has been more than 5 years since our reaction, so we wouldn't give any points here. And the patient did not mention any sort of anaphylactic reaction or angioedema. We only saw this rash that appeared. There was no severe cutaneous adverse reaction noted, so he would get no points there. But he did receive diphenhydramine to kind of help alleviate the rash. So this would kind of qualify as our treatment required for reaction and give us a total of 1 point, giving us that low risk of penicillin allergy. But now that I've mentioned a couple times that this is what's done elsewhere, what do we do here at Norton? What is our policy here? And what we do here at Norton is actually going to be our clear pen protocol. So this is going to be looking to use desensitization and oral challenge order sets as well. So beyond our clear pen, we can also use some order sets that we'll talk about here in a little bit. But primarily for right now, we're just going to be talking about clear pen. And so what is clear pen? Clear pen is part of the antimicrobial stewardships team here to reconcile penicillin allergy histories in adult patients suspected to potentially tolerate penicillins. And we really are going to be screening these patients for education and allergy reconciliation with the goal to provide education, to delabel eligible patients, and optimize our future selection towards first-line agents when possible. Just keeping in mind that not all allergies are significant. So this protocol actually is very unique in the sense that it does involve pharmacy and nursing kind of working in tandem to be able to do this effectively. So we utilize nursing allergy history review and in a way to help identify our patients with clinically insignificant reactions and our low risk reactions, which we'll talk about kind of the difference between those here in a second. But if you've ever noticed when we look at our penicillin allergy history, you might see a little green box below the allergies. And if you pull out to the tab, you can see a flow sheet. And actually, that whole flow sheet is done by nursing. When patients are admitted, you just kind of have a quick question series answered, and we use that to be able to go in, select our patients that are appropriate for delabeling, appropriate for challenging, and go from there. But now you might be wondering, well, if that's what we do to include our patients, who do we exclude when we're looking to utilize our clear PIN protocol? So we're going to exclude, similar to kind of what those 2022 guidelines recommend, we're going to exclude our patients that have severe reactions. So these are patients that have anaphylaxis history, so the angioedema, the shortness of breath, the hypotension, the hives with other organ involvement, like nausea or vomiting. I'm sure y'all are tired of me talking about that by this point, but just always like to stress it. Similarly, we're going to look out for our severe cutaneous reactions, such as Stevens-Johnson syndrome, toxic epidermal necrolysis, or even our drug reaction with eosinophilia and systemic symptoms. Some other exclusions that we can see, just specifically for our oral challenges, could be due to clinical status restrictions. So a patient that's currently in the ICU, a patient who can't take oral, they're MPO, they have an altered mental status. These people are going to be excluded from our clear PIN. Likewise, patients with interfering medications such as scheduled diphenhydramine or H1 antagonist within 72 hours, or even receipt of a scheduled systemic steroid within 72 hours. These are going to kind of be some of our exclusion criteria when we look to say, oh, this isn't someone that we can actually look to do a clear PIN process for. These are not all of our exclusion criteria, but just some of the more common ones that we can see. And our clear PIN protocol does kind of go into a bit more specifics regarding whether or not patients are fully excluded or can be included in this process. So as I mentioned, there are two different types of reactions that this process kind of identifies, are clinically insignificant and low risk reactions. And we're just going to start by talking about our clinically insignificant reactions. And these are going to be reactions that are defined as non-itching rashes or drug intolerances. They're also not going to have a documented reaction and have taken amoxicillin without issue since. So this is not has to be non-itching rash or drug intolerance and the documented reaction. This is either or. So a patient can have the non-itching rash or having no documented reaction and take an amoxicillin without issue since. This is going to be a situation where we actually have a discussion with the patient, educate them on the risks of having that labeled allergy, and if the patient is okay with it, after verifying that this allergy history is appropriate and accurate, and they don't meet any other exclusion criteria, we can go ahead and remove the reaction from the EHR if appropriate. On the other hand, our low-risk reactions are a little bit different. So this is going to be patients that either have hives or itching rash, so non-blistering rashes that occurred at least 10 years ago or in childhood, or they have an unspecified penicillin allergy and have taken cephalexin since. So for these patients, it's not going to be just having that simple conversation with a patient, educating them, verifying their history. We're also going to want to discuss with the patient and the provider and offer an oral amoxicillin challenge if both parties are agreeable or are agreeable to being able to do this after we have kind of discussed with the patient, making sure that this allergy history is validated and verified. So once we've talked with the provider, talked with the patient, we get the okay from both of them. This is where we can go ahead and give our oral amoxicillin challenge. And then if they appropriately tolerate it and the patient wants to do this, we can go ahead and remove or update the reaction from Epic, just depending on kind of what the patient prefers. Because sometimes people do still prefer to leave the allergy on, but they would be okay with you updating the allergy in Epic itself. And just as a way to kind of exemplify how this would look in practice, so this 73-year-old male has a labeled penicillin allergy history with a reaction of immunity against the antibiotic because he received it a lot as a child. So based on our clear PIN guidance, which category of reaction does this fall under and what intervention could subsequently be made? So is this a clinically insignificant reaction where we recommend an amoxicillin challenge? Is this a low risk reaction where we remove the allergy from the EHR per protocol? Is this a clinically insignificant reaction where we discuss with patients to remove the labeled allergy from the EHR, or is this a low risk reaction where we just go ahead and give and recommend our amoxicillin challenge? So based on kind of where we see the differences between our clinically insignificant and low risk reaction, this patient has that kind of intolerance, not described reaction. This would be a clinically insignificant reaction. This is where we would go and have that discussion with the patient one-on-one, validate their allergy, discuss with them the benefits of removing this allergy and delabeling them. And if they are agreeable to it, remove the labeled allergy from the EHR. Another example here, this is going to be a 43-year-old female, has always been told she had an itchy rash after receiving amoxicillin as a child, but does not actually recall the reaction herself. Based on ClearPen guidance, which category of reaction does this fall under? And what intervention could subsequently be made? So we could look at this as, is this a clinically insignificant reaction where we remove the allergy per protocol? Is this a low risk reaction where the patient is okay to receive amoxicillin normally? Is this a clinically insignificant reaction where we recommend a one-step amoxicillin challenge? Or is this a low-risk reaction where we recommend amoxicillin challenge after discussing with the patient and provider? And for this, we would actually see this as a low-risk reaction. We have this patient that did have the history of an itchy rash. It happened to them as a child. They might not be fully sure, but that is what they've been told throughout their whole life. But doesn't recall the reaction herself. We're going to have that low risk reaction here and recommend an amoxicillin challenge after discussing with the patient and the provider to make sure all parties are in agreement, well educated on the matter, and just kind of how we could go forward with this and hopefully be able to challenge and delabel this patient's allergy history. And finally, one more example for you guys. While on rounds, you encounter a patient with a penicillin allergy with no details listed from 2015 in the EMR. So upon further chart review, you find he had received cephalexin for 5 days inpatient for cellulitis 4 years ago. What is the best action to take? Is it nothing? Just continue on rounds with the team? Is it speak to the patient, reconcile, educate, and delabel their allergies documented or their documented allergy history? Or should we speak to the patient with the mind to offer an amoxicillin drug challenge to clarify and delabel the documented allergy if the patient does not have a true allergy or reaction? So for this, we would actually want to speak with the patient, offer that amoxicillin drug challenge to clarify and delabel them, as this is kind of one of those situations where we have the low risk reaction. So they don't have the details listed on our penicillin allergy. We can't say one way or the other. If it was a situation where someone might have had an itchy rash, they're not sure, but we do see that they've tolerated cephalexin. So this would actually put us in that low risk reaction and kind of lead us down to that conversation with the provider, with the patient, and look to offer them a drug challenge to clarify and delabel. And as I did mention earlier, beyond our ClearPen, we do have our desensitization and drug challenge order sets. So this provides orders to effectively monitor an oral or an IV challenge or desensitizations, and they are all available within Epic. As you can see here, this is kind of what we have now with our adult medication desensitization protocol. This name might change somewhat soon, but for the most part, everything on the end that's remaining in this order set will remain in place. The name just might get a different change, which will be updated and kind of told to everybody, educated to everybody whenever that happens. But you might be wondering, well, what's included in our drug challenge order sets and our desensitization order sets? So really, this is where we're going to look to have our rescue medications, our epinephrine, our diphenhydramine, our methylprednisolone, as well as nursing communications on how to manage symptoms and orders for alerting the primary team if any issues arise. It also kind of provides instructions for patients regarding when to use the call lights, alert the medical team, just essentially gives nurses a step-by-step and it gives them plenty of instructions so they can help manage their patients going through these oral or IV drug challenges or a desensitization as well. So this is a lot to take away, but in general, our key takeaways from kind of thinking about our beta-lactam cross-reactivity is just really having that awareness of cross-reactivity. are similar or dissimilar side chains, and how we can kind of take our knowledge of cross-reactivity risk to facilitate safe use of a beta-lactam antibiotics and just selecting the appropriate antibiotic whenever we can, if at all possible. Likewise, we can also look to utilize institutional allergy management guidance to assist in delabeling and educating patients and providers. And this is something that we do fairly frequently with our ClearPen protocol, as well as having some of our order sets for desensitization and our rescue medication order sets, and just monitoring our challenges as well as desensitizations. So with that, that is this presentation on crisscross by cross reactivity. I hope you all learned something today, and I thank you for your time.